I'm Dr. Catherine Reeves, and I've been an orthopedic surgeon at Riverside General Medical Center in Portland, Oregon for 18 years. Or at least I was, until I submitted my resignation 6 weeks ago. During my career, I've performed over 400-200 bone surgeries, reconstructed limbs that seemed beyond saving, and helped patients regain mobility when everyone else had given up hope. But what I'm about to tell you about is the one fracture case that made me question everything I thought I knew about bone healing, human recovery, and the very boundaries of what medical science considers possible. Riverside General Medical Center sits in the heart of Portland's medical district, a sprawling 500-bed facility that serves as the primary trauma center for Oregon, Southern Washington, and parts of Northern California. As the chief of orthopedic surgery, I oversee a department that handles some of the most complex bone and joint injuries on the West Coast. My journey into orthopedic surgery began during my residency at Johns Hopkins, where I was drawn to the precise, mechanical nature of bone repair. Unlike other medical specialties that deal with abstract conditions and uncertain outcomes, orthopedic surgery felt concrete and definitive. Bones break in predictable patterns. They heal according to established timelines. Surgery follows logical protocols that, when executed properly, produce measurable results. Over 18 years, I'd built a reputation for taking on the impossible cases. Mountain climbing accidents where climbers fell hundreds of feet onto rocky terrain. Motorcycle crashes that left riders with bones shattered into dozens of fragments. Industrial accidents that crushed limbs beyond what most surgeons would even attempt to repair. My surgical suite, or 7, had become known throughout the hospital as the reconstruction zone. It was equipped with the most advanced orthopedic hardware available, titanium plates that could be custom bent to match any bone contour, screws of every conceivable size and threading, and bone graft materials that could fill gaps where natural bone had been completely destroyed. My team reflected this commitment to complex cases. Samantha Torres, my lead surgical technician, had been with me for 12 years. She could anticipate which instrument I needed before I asked for it, and her knowledge of bone anatomy rivaled that of many surgeons. Dr. Benjamin Walsh, my anesthesiologist, specialized in maintaining patients through marathon surgical procedures that could stretch 8, 10, sometimes even 12 hours. The nursing staff in our orthopedic wing knew the rhythms of complex fracture recovery better than anyone. They understood that patients with severe bone trauma faced months of immobilization, weeks of excruciating pain, and rehabilitation timelines that stretched far longer than most people could imagine. Understanding what makes my story so extraordinary requires understanding the rigid biological laws that govern bone healing. These aren't medical theories or educated guesses. They're fundamental principles of human biology that I'd observed in thousands of cases over nearly 2 decades. When a bone breaks, the healing process follows 4 distinct phases. First, inflammation occurs as blood vessels in the bone are damaged, and a hematoma forms around the fracture site. This takes 24 to 48 hours, and is accompanied by significant swelling and pain. Second, soft callus formation begins as specialized cells called osteoblasts start producing new bone tissue. This process takes 2 to 3 weeks minimum, and creates a soft, fibrous bridge across the fracture gap. Third, hard callus formation transforms the soft tissue bridge into actual bone material. This phase requires 6 to 12 weeks, and is where the real structural healing occurs. Finally, bone remodeling can take months or even years, as the newly formed bone is gradually reshaped to match the original bone's strength and structure. These timelines aren't suggestions. They're biological constants that I'd never seen violated in 18 years and over 4,000 surgeries. A femur fracture takes a minimum of 12 weeks to heal enough for weight bearing. Complex fractures with multiple fragments require 16 to 20 weeks or longer. Compound fractures where bone has protruded through skin need even more time due to infection risk and soft tissue damage. Surgical intervention can stabilize fractures and improve outcomes, but it cannot accelerate the fundamental cellular processes that rebuild bone tissue. The hardware we install, plates, screws, rods, provide structural support while natural healing occurs, but the bone itself still needs to regenerate according to its own biological timeline. In severe cases involving multiple fractures, patients often require 12 to 18 months to return to normal function. Some never fully recover, living with permanent limitations in mobility, strength, or range of motion. These weren't arbitrary medical guidelines. They were the immutable laws of human physiology that every orthopedic surgeon learns, respects, and plans treatment around. The case that would ultimately end my career began on a rain-soaked Thursday morning in March 2024. Portland was experiencing one of its notorious spring storms, with sheets of rain making driving treacherous throughout the city. I was in my office at 6:15 a.m., reviewing surgical schedules for what promised to be a busy day. At 6:47 a.m., my pager buzzed with an urgent message from Dr. Michael Chen, our emergency department chief. Major trauma incoming, ETA 12 minutes. Multi-vehicle accident, priority red patient with severe orthopedic injuries, need you in trauma 1 immediately. I grabbed my surgical cap and headed for the trauma bay, where Samantha was already setting up emergency orthopedic equipment. After 12 years together, she could read the urgency in these calls as well as I could. "What are we looking at?" she asked as we prepped the trauma room. "Multi-vehicle accident. That usually means high-impact injuries, probably multiple fractures. Have the full reconstruction kit ready and prep OR7. Dr. Walsh arrived moments later, along with our trauma nursing team. The familiar pre-emergency tension filled the room as we waited for the ambulance arrival. At exactly 6:59 a.m., the automatic doors burst open, and the paramedics wheeled in what would become the most extraordinary case of my career. The patient was Isabella Martinez, a 31-year-old veterinarian from the Selwood neighborhood of Portland. According to the paramedic report, she had been driving to an emergency call when a delivery truck ran a red light at the intersection of McLaughlin Boulevard and Milwaukee Avenue, striking her Toyota Camry at approximately 45 miles per hour on the driver's side. The impact had been devastating. Isabella's car had been crushed against a concrete barrier, trapping her in the wreckage for nearly 40 minutes while rescue crews used hydraulic tools to extract her from the mangled vehicle. "What's the primary injury?" I asked the lead paramedic as we transferred Isabella to our trauma table. "Left leg took the worst of it. The door frame crushed inward and pinned her leg against the transmission tunnel. We're looking at what appears to be a complete compound fracture of the femur, with multiple secondary fractures throughout the tibia and fibula. She's been conscious and responsive throughout transport, but she's lost significant blood." My initial visual assessment confirmed the severity of the situation. Isabella's left leg was grotesquely deformed, swollen to nearly twice its normal size, with clear signs of multiple fracture points beneath the skin. More concerning was the compound fracture, where bone had punctured through the skin near her thigh, creating an open wound that significantly increased infection risk. "Isabella, can you hear me?" I asked, checking her responsiveness while the trauma team worked around us. "Yes," she replied weakly but clearly. "How bad is it, doctor? I can't feel my leg." Her inability to feel the leg was concerning but not unexpected given the apparent nerve damage. What struck me was her remarkable coherence despite the trauma she'd endured. "We're going to take very good care of you," I told her. "I need to examine your leg and get some x-rays, then we'll know exactly what we're dealing with." The x-rays came back within minutes, and they revealed one of the most complex fracture patterns I'd encountered in my career. Dr. Lisa Park, our lead radiologist, met me at the viewing station with an expression I recognized, the look she got when dealing with truly catastrophic injuries. "Catherine, this is extensive," she said, pointing to the images displayed on the screen. "The femur has a complete transverse fracture at mid-shaft, plus a secondary fracture at the neck. The tibia shows 3 distinct fracture lines, proximal, mid-shaft, and distal. The fibula is fractured in 2 places with what appears to be a floating bone segment in the middle." I studied the x-rays carefully, counting fracture lines and assessing the displacement of bone fragments. In total, Isabella had 7 separate fractures in her left leg, with bone fragments scattered throughout the soft tissue. "What's the prognosis for reconstruction?" Dr. Park asked. I considered the question carefully. With this level of damage, we're looking at multiple surgeries over several months. The compound fracture increases infection risk significantly. Even with perfect surgical execution, she's facing 18 to 24 months of recovery, and there's a substantial chance of permanent disability. The severity went beyond just the number of fractures. The compound nature of the femur break meant that infection was a constant threat. The multiple fracture points in both the tibia and fibula suggested that her lower leg had essentially been crushed, requiring extensive reconstruction with hardware. Most challenging of all was the apparent nerve damage. Isabella's inability to feel her leg indicated potential injury to the sciatic nerve, which could result in permanent loss of sensation and motor function even if the bones healed perfectly. "Are we looking at possible amputation?" Dr. Park asked quietly. It was the question every orthopedic surgeon dreads, but one we have to consider in cases this severe. Let's see what we find when we get in there. If the vascular supply is compromised, or if there's too much soft tissue damage, We might have to make some difficult decisions. I returned to Isabella's bedside to explain what we'd found and what lay ahead. These conversations are among the most difficult aspects of orthopedic surgery, explaining to a patient that their life is about to change dramatically, that the road to recovery will be long and uncertain, and that even with the best possible outcome, they may never be the same. Isabella, the X-rays show extensive fractures throughout your left leg. I began. Your femur, that's your thigh bone, is broken in 2 places. Your tibia and fibula, the bones in your lower leg, are fractured in multiple locations. We're going to need to perform surgery to reconstruct your leg using metal plates and screws. She absorbed this information with remarkable composure. Will I be able to walk again? That's our goal, but I need to be honest with you about the challenges ahead. The surgery will be complex, probably 6 to 8 hours. You'll be in the hospital for at least a week, then face months of rehabilitation. Even in the best case scenario, you're looking at 12 to 18 months before you might return to normal activities. And the worst case scenario, I hesitated, but she deserved honesty. There's a risk of infection, permanent nerve damage, or complications that might require additional surgeries. In extreme cases, if the leg can't be saved, amputation becomes a consideration. Isabella was quiet for a long moment, processing the magnitude of what I'd told her. Finally, she looked at me with determined eyes. Dr. Reeves, I'm a veterinarian. I work with animals who recover from injuries that seem impossible. If there's any chance of saving my leg and restoring function, I want to try. Her courage in the face of such devastating news reminded me why I'd chosen orthopedic surgery in the first place. We're going to do everything possible to get you back on your feet. Isabella's surgery began at 9:30 a.m. and would become one of the most complex bone reconstructions of my career. The operating room was prepared with multiple sets of orthopedic hardware, bone graft materials, and specialized equipment for dealing with compound fractures. Samantha, we'll need the large fragment set for the femur, the trauma plates for the tibia, and have the bone graft substitutes ready, I instructed as we began the procedure. The first challenge was cleaning and assessing the compound fracture site. When bone breaks through skin, debris and bacteria enter the wound, creating significant infection risk. We spent nearly an hour carefully cleaning the wound and removing contaminated tissue. What I found when I opened Isabella's leg was even more extensive than the X-rays had suggested. The femur fracture had created multiple bone fragments that were scattered throughout the muscle tissue. Some fragments were so small they looked like bone gravel embedded in the soft tissue. This is going to take longer than I thought, I told Dr. Walsh. The fragmentation is extensive. Each piece needs to be carefully repositioned or removed. The femur reconstruction alone took 4 hours. We used a long titanium plate secured with 8 screws to bridge the main fracture, then carefully repositioned dozens of smaller fragments, securing each with wire or small screws. The precision required was extraordinary. Each fragment had to be placed in exactly the right position to restore the bone's natural strength and alignment. The tibia reconstruction proved equally challenging. With 3 separate fracture sites, we needed to install 2 titanium plates connected by a complex rod system. The floating bone segment in the fibula required a complete removal and replacement with bone graft material. How's she holding up, Ben? I asked Dr. Walsh during hour 6 of the surgery. Vitals are stable, but she's requiring more anesthesia than usual to maintain unconsciousness. Her body seems to be fighting to wake up, which is unusual for this type of trauma. By hour 7, we had successfully reconstructed Isabella's shattered leg. The hardware installation was extensive: 4 titanium plates, 2 rods, and 37 screws of various sizes. X-rays taken during surgery confirmed proper positioning of all hardware and adequate alignment of the reconstructed bones. That's some of the finest orthopedic reconstruction I've ever seen, Samantha commented as we prepared to close the surgical site. I agreed, but I also knew that successful surgery was only the beginning. The real test would be whether Isabella's body could heal around all the hardware we'd installed, and whether the extensive nerve damage would allow for functional recovery. The surgery concluded at 5:45 p.m., 8 hours and 15 minutes of meticulous bone reconstruction. According to every principle I knew, Isabella faced months of immobilization, extensive physical therapy, and a recovery timeline that would stretch well into 2025. Isabella was transferred to our orthopedic intensive care unit for post-surgical monitoring. Complex fracture cases require careful observation for complications like infection, blood clots, or hardware failure. I expected her to remain unconscious for several hours as the anesthesia wore off, then face days of severe pain as her body began processing the surgical trauma. At 8:30 p.m., just under 3 hours after surgery, I received a call from Maria Santos, our head orthopedic nurse. "Dr. Reeves, I think you need to see Isabella Martinez. Something's not right." "What kind of complication are we looking at?" I asked, immediately concerned about post-surgical issues. "That's just it. It's not a complication. She's awake, alert, and asking when she can go home." I hurried to the ICU, expecting to find a disoriented patient experiencing the confusion that often follows lengthy surgeries. What I found instead was Isabella sitting up in bed, looking remarkably alert and comfortable. "Dr. Reeves, how did the surgery go?" she asked as I approached her bed. Her clarity surprised me. Patients typically remain groggy for hours after extended anesthesia, especially following traumatic surgeries. "The surgery went very well, Isabella. We were able to reconstruct your leg and save the limb. How are you feeling?" "That's what's strange," she replied. "I feel good. Really good, actually. The leg doesn't hurt much at all. This was medically impossible. 8 hours of bone reconstruction, extensive hardware installation, and manipulation of severely traumatized tissue should have left her in excruciating pain, despite our post-surgical pain management protocols." I examined her surgical site, expecting to find the massive swelling and inflammation that always accompanies complex orthopedic procedures. Instead, the swelling was minimal, and the incision sites looked remarkably clean and well-positioned. "Isabella, I need to be completely honest with you. What you're experiencing isn't normal. Patients who undergo the level of surgery you just had typically experience significant pain for days or weeks." She looked at me with clear, focused eyes. "I understand that sounds impossible, Dr. Reeves, but I feel like I could get up and walk right now." "Absolutely not," I said firmly. "The bones need time to begin healing around the hardware. Any weight bearing right now could cause catastrophic failure of the entire reconstruction." But even as I said it, I was looking at a patient who showed none of the expected signs of surgical trauma. Her color was good, her pain levels were minimal, and most remarkably, she seemed to have more energy than most people have on a normal day. I ordered new x-rays to verify the hardware positioning and check for any immediate complications. The images came back an hour later, and Dr. Park called me immediately to the radiology department. "Catherine, you need to see these films," she said, displaying Isabella's post-surgical x-rays alongside images from the morning. What I saw challenged every principle of bone healing I'd learned in medical school. The fracture lines that had been clearly visible that morning were already showing signs of healing activity. More impossibly, there appeared to be new bone formation bridging several of the fracture gaps. "Lisa, these can't be from the same patient. Bone healing this rapid is medically impossible. I've triple-checked the patient identification, timestamps, and imaging protocols. These are definitely Isabella Martinez's x-rays, taken approximately 4 hours post-surgery." I stared at the images in disbelief. What I was seeing suggested bone healing that typically takes 6 to 8 weeks minimum. The titanium hardware we'd installed was already showing signs of integration with the surrounding bone tissue, a process that normally requires months. "Have you ever seen anything like this?" I asked Dr. Park. "In 20 years of radiology, never. Not even close. Catherine, I don't know how to explain what these images show." Neither did I. Everything I understood about orthopedic medicine said that what I was looking at was impossible. The next morning brought even more impossible developments. Isabella had slept comfortably through the night, unusual for post-surgical patients who typically experience significant pain and discomfort. When I arrived for morning rounds, I found her sitting up, reading a veterinary journal, and looking remarkably well.
"Good morning, Dr. Reeves," she said cheerfully. "I've been thinking about what you said yesterday, about the recovery timeline. I understand why you're being cautious, but I honestly feel completely normal." I pulled back her covers to examine the surgical site, and was astounded by what I saw. The massive surgical incisions from the day before looked like they'd been healing for weeks. There was minimal bruising, no signs of inflammation, and the sutures appeared to be already integrating with the skin tissue. "Isabella, this level of healing in 24 hours is medically impossible. Let me ask you something. Have you ever healed unusually quickly from injuries before?" She thought for a moment. "Actually, now that you mention it, yes. When I was in veterinary school, I broke my wrist in a skiing accident. The doctors said it would take 6 to 8 weeks to heal, but I was back to normal activities in about 3 weeks. They said I was just lucky." This suggested that Isabella might have some genetic or physiological characteristic that enabled accelerated healing, but even that couldn't explain what I was witnessing. "I'd like to run some blood tests and get another set of x-rays," I told her. "What's happening here is unprecedented, and I want to make sure we understand it." The blood tests came back that afternoon, with results that added another layer of mystery to Isabella's case. Her inflammatory markers, The blood chemistry indicators that show how the body is responding to trauma and surgery were completely normal. In a typical post-surgical patient, these markers would be elevated for weeks following complex orthopedic procedures. More intriguingly, her bone metabolism markers showed activity levels I'd never seen before. The blood chemistry indicated that her body was producing new bone tissue at a rate far exceeding normal parameters. Dr. Jennifer Wu, our head of laboratory medicine, called me personally to discuss the results. "Catherine, I've been running bone metabolism panels for 15 years, and I've never seen numbers like these. Isabella's osteoblast activity, the cells that build new bone, is operating at nearly 10 times normal levels. Her calcium uptake is extraordinary. It's like her entire skeletal system has been put into overdrive. What could cause that kind of accelerated bone metabolism? I honestly don't know. There are some rare genetic conditions that affect bone formation, but nothing that would produce these kinds of numbers, and certainly nothing that would be triggered by trauma." By the third day post-surgery, Isabella's recovery had progressed beyond anything I'd encountered in 18 years of orthopedic surgery. The X-rays showed continued rapid bone fusion, with fracture lines becoming increasingly difficult to identify. The titanium hardware was being incorporated by new bone growth at an impossible rate. Most remarkably, Isabella was insisting that she felt ready to attempt walking. "Dr. Reeves, I understand your concerns, but I feel stronger than I did before the accident. Something extraordinary is happening, and I think we need to acknowledge it." Against every protocol and principle I knew, I agreed to let Isabella attempt limited weight bearing, with extensive support and monitoring. If her bones were healing as rapidly as the imaging suggested, traditional timelines might not apply. With the help of our physical therapy team, Isabella slowly stood and took her first tentative steps. What happened next would haunt me for the rest of my career. She walked across the room with minimal assistance, showing no signs of pain, instability, or structural weakness in the reconstructed leg. Her gait was nearly normal, with only slight favoring of the surgical leg that was barely detectable. "How does it feel?" I asked, still unable to believe what I was witnessing. "It feels perfect," she replied. "Actually, it feels stronger than it did before the accident. It's like my entire leg was rebuilt, but better than the original." On day 5 post-surgery, I made a decision that went against every principle of orthopedic medicine I'd ever learned. I discharged Isabella Martinez with a completely healed leg. The X-rays showed bone fusion that typically takes 12 to 16 weeks to develop. The surgical incisions had healed as if the surgery had been performed months earlier. Her range of motion was complete, her strength was normal, and she reported no pain or discomfort. "Isabella, what you've experienced is unprecedented in my 18 years of practice," I told her during our discharge consultation. "I've never seen bone healing like this. I need you to promise me you'll be careful and come back immediately if you experience any problems." "Dr. Reeves, I feel better than I have in years. It's like my body found a way to not just heal, but to improve. I can't explain it, but I'm grateful for whatever happened." As she walked out of my office that day, walked normally, confidently, on a leg that had been shattered beyond repair just 5 days earlier, I felt the first crack in the foundation of everything I thought I knew about medicine. 6 weeks later, Isabella returned for her scheduled follow-up appointment. The X-rays showed perfect bone fusion with no trace of the original fractures. The titanium hardware was completely integrated, and her leg function was not just normal, it appeared to be superior to baseline. She had returned to her veterinary practice and was working full-time with no limitations. If anything, she reported feeling more energetic and physically capable than before her accident. "Dr. Reeves, I've been thinking about what happened to me," she said as our appointment concluded. "Do you think this kind of healing could happen to other people? Because I've been wondering if maybe we don't understand everything about how the human body can recover from severe trauma." Her question would echo in my mind for months afterward. As she left that day, walking perfectly on a leg that medical science said should have taken over a year to heal, I couldn't shake the feeling that I had witnessed something that challenged the very foundation of orthopedic medicine. What I didn't know then was that Isabella's case was just the beginning. What I was about to discover in the coming months would force me to question everything I thought I knew about bone healing, human recovery, and the hidden potential of the human body to accomplish the impossible. The fracture that healed in 5 days would haunt me, because it proved that sometimes the impossible is just medicine we don't understand yet. 3 months after Isabella's discharge, I encountered something that would shatter my remaining faith in conventional medicine. Marcus Chen, a 45-year-old ironworker, arrived at Riverside General after a construction crane collapsed, crushing his pelvis and both legs in what should have been a career-ending, if not life-ending accident. The X-rays showed devastation that made Isabella's injuries look minor by comparison.
Marcus had 17 separate fractures across his pelvis, femurs, tibias, and fibulas. His left hip socket was completely shattered. By every medical standard, he was looking at multiple surgeries, years of rehabilitation, and probable permanent wheelchair use. The reconstruction surgery took 14 hours, the longest of my career. We installed enough titanium hardware to set off airport metal detectors permanently. When Marcus woke up the next morning, I prepared myself for the typical post-surgical conversation about long recovery timelines and realistic expectations. Within 72 hours, his x-rays showed the same impossible bone healing I'd witnessed with Isabella. Within a week, he was walking. Within 2 weeks, he had returned to construction work with strength and mobility that exceeded his pre-accident levels. The case that convinced me I was witnessing something beyond medical anomaly occurred 6 months later. Sarah Kim, a 28-year-old rock climbing instructor, fell 80 feet at Smith Rock State Park, sustaining what our trauma team called the worst spinal fracture combination they'd ever seen survive. Her spine was fractured in 7 places from her neck to her lower back. The neurosurgery team prepared her family for probable paralysis if she survived at all. I was called in to address the multiple rib fractures and a shattered collarbone that seemed minor compared to her spinal injuries. But Sarah's recovery followed the same impossible pattern. Complete spinal fusion occurred in days rather than months. Her rib fractures healed overnight. Most remarkably, she retained full neurological function despite spinal cord damage that should have caused permanent paralysis. 3 weeks after her fall, Sarah was teaching rock climbing again. After Sarah's case, I began documenting every detail of these impossible healings. I researched medical literature for similar cases and found scattered reports of spontaneous bone regeneration and accelerated fracture healing dating back decades, but always dismissed as measurement errors or misdiagnosed injuries. I started asking more detailed questions during post-surgical follow-ups with other patients. What I discovered was staggering. Approximately 20% of my complex fracture cases showed some level of accelerated healing that defied medical explanation. Most patients didn't think to mention it, assuming their recovery was normal. But when I specifically asked about healing speed, energy levels, and functional improvement, the pattern became undeniable. I contacted researchers at major medical universities, sharing anonymized case data. Dr. Robert Santos at Stanford was intrigued but skeptical. "Catherine, what you're describing challenges fundamental principles of bone biology. If this phenomenon is real, it represents a complete paradigm shift in our understanding of human healing capacity." As word of my miraculous recoveries spread through the medical community, my colleagues' reactions ranged from skepticism to outright hostility. Dr. Patricia Williams, Riverside's chief of staff, called me into her office after Isabella's case became hospital gossip. "Catherine, your surgical outcomes are impressive, but your claims about accelerated healing are concerning the medical board. Patients and families are asking why their loved ones don't receive the same miraculous treatment." "Patricia, I'm not doing anything different surgically. These patients are healing at rates that defy current medical understanding. We need to study this phenomenon, not suppress it. What we need is for you to return to evidence-based medicine and stop making claims that can't be substantiated." But I couldn't ignore what I'd witnessed. How could I continue practicing orthopedic surgery, knowing that some patients possessed healing capabilities we didn't understand? How many others might benefit if we could identify what triggered these impossible recoveries? My relationships with colleagues deteriorated. My surgical schedule was quietly reduced. Whispers followed me through hospital corridors about the surgeon who had become obsessed with medical impossibilities. The case that ended my career occurred 8 months after Sarah's climbing accident. Elena Rodriguez, a 52-year-old teacher, suffered complete bilateral leg fractures in a head-on collision. Both legs were shattered so extensively that amputation seemed inevitable. I spent 16 hours reconstructing what remained of her legs, installing more hardware than I'd ever used in a single surgery. Elena's recovery followed the same impossible pattern: rapid bone fusion, minimal pain, extraordinary strength improvement. But this time, hospital administration demanded an investigation. How was I achieving impossible results? What experimental procedures was I using? The medical board questioned whether I was falsifying records or using unauthorized treatments. The investigation found no wrongdoing, because there was none. I was simply a surgeon who had witnessed something that challenged everything medicine thought it knew about human healing capacity. 6 weeks ago, I submitted my resignation to Dr. Williams. "Catherine, you're one of our finest surgeons. Don't throw away your career over a few unusual cases." "Patricia, I've witnessed dozens of patients heal at rates that shouldn't be possible." Isabella Martinez walked out of here in 5 days with a completely reconstructed leg. Marcus Chen returned to construction work in 2 weeks after 17 fractures.
Sarah Kim is teaching rock climbing, 3 weeks after spinal fractures that should have left her paralyzed. Medical anomalies happen, Catherine. You know that. Not like this. Not with this consistency. There's something fundamental about human healing capacity that we don't understand. And I can't keep practicing medicine based on incomplete knowledge. I now work as a family physician in a small coastal town in Oregon, treating common ailments and avoiding any cases involving complex trauma. But I continue researching accelerated healing phenomena from a distance. Isabella Martinez recently sent me a photo of herself completing a marathon, something she'd never been able to do before her accident. Marcus Chen returned to competitive powerlifting and is stronger than he was in his 20s. Sarah Kim now free climbs routes she couldn't attempt before her fall. All three have asked me the same question. Dr. Reeves, why us? Why were we able to heal this way when others can't? I don't have an answer. What I do know is that witnessing their recoveries changed my understanding of human potential, medical limitations, and the mysteries that still exist within the human body. The fractures that healed in impossible timeframes will haunt me forever, not because they were terrifying, but because they revealed how much we still don't know about the extraordinary healing capacity hidden within us all. Sometimes, late at night, I wonder how many other patients might possess this remarkable ability to heal, but never discover it because we don't know how to recognize or trigger it. That's a question too profound for current medical science to answer, and too important for any single surgeon to carry alone. The impossible healings continue to occur. We just haven't learned how to see them yet.